Welcome, everybody.
Well, thank you. And I know you have heard a lot today, and as you said, you've got more time allocated for tomorrow. I appreciate the opportunity to comment on this. This is a new proposal. Certainly we've not had a chance to weigh into the various provisions. I'd like to reiterate our concern about the analysis of managed care and its implications for Maine, given what is already underway in the state of Maine around reform and the support of primary care and the work that's being done with the creation of the health homes and the accountable communities. Part of the issue that I think is critically important to focus on is we are, as you know, forecasting a 0.8% increase in total Medicaid spending from state fiscal year 13 to 14, and slightly more than 1% from state fiscal year 14 to 15. The trend nationally is closer to 4 and 5%, and that is with states that already have Medicaid managed care. We recognize that there are significant provisions federally governing Medicaid managed care, some of which pertain to the requirement related to actuarial analysis, and we have grave concerns about both the cost associated with Medicaid managed care companies, the protections that exist under the federal Medicaid managed care requirements, and fundamentally, as we have talked with providers, as we have rolled out the health homes, and certainly, frankly, as we went through the MaineCare redesign task force meetings, what we heard as a refrain from providers consistently, physician practices, SQHCs, hospitals, why would you bring in an out-of-state company and pay that company to hire nurse care managers and case managers when we are investing in that staff today in our practices? That physician practices, hospitals are making investments locally and would like to see any reimbursement for those services to occur directly with providers. We saw a great opportunity to have that local partnership with providers and to support the development of that infrastructure, because we believe that the impact related to utilization, to address issues around avoidable hospitalizations, reduced emergency department use, readmissions, that fundamentally the impact was going to be between a patient and their physician in the practice with a nurse care manager, as opposed to the infrastructure of an out-of-state company. We still believe strongly in the pathway that we are on. We question the duplicative nature of this structure. Certainly, as you know, we've invested tens of millions of dollars in a new claims management system that is paying providers timely, accurately, paying for claims that previously were not paid for under MIMS. These managed care companies would obviously also have to stand up claims management systems as well. So there's a great deal of concern about duplication with those administrative costs, as well as duplicating the work that is already underway throughout the state in that investment of local healthcare infrastructure around a much more robust primary care system. I have asked our director of the Office of Aging and Disability Services to accompany me here today, because there are other provisions in the bill that I didn't know if we might have time to address today related to individuals with intellectual and developmental disabilities and the elderly. So I don't know if you would allow us just a few brief moments to comment on that.
Please go ahead. We will stay here as long as you need.
Okay, thank you. Jim?
Thank you, Commissioner. Good afternoon. Nice to see everybody here again. Senator Craven, Representative Farnsworth, and members of the committee. My name is Jim Martin. I am the Director of the Office of Aging and Disability Services. And as the Commissioner just said, I'm here to give some feedback on Part G of the bill specifically, which Senator Kate went over and described briefly, that speaks to adults with intellectual disabilities and autism. And the department really is wanting to share with you the work that is underway that addresses the concerns and the high costs that are also described in this bill. So I wanted the opportunity to reinforce that, and some of this you have heard as I've been in front of you before. The department in the Office of Aging Disability Services has undertaken an initiative called Supporting Individual Success, or also the Supports Intensity Scale. The initiative is implementing a standardized assessment process conducted by a third-party entity, enhancing the importance of informed person-centered planning, and it's also creating a resource allocation model that will incentivize employment and it'll incentivize independence. For the past several years, the challenge within the DD system has been the governance of a fee-for-service structure that has been paying providers by volume. In the past 7 years at least, our efforts to implement solutions have included unilateral rate reductions, changes in the service quality, and overall unit-by-unit utilization management. Our point of moving forward with the supports intensity scale is to build a system differently than what we've tried over the past handful of years. It's important to us that we build a Maine-specific structure that's sustainable. So as you know, and we believe in this wholeheartedly, changing the developmentally disabled service system specifically requires full participation of providers, families, government, advocates, and most notably consumers, clients that we're serving. So in our view, it's irresponsible and it's irresponsible to assume or act on reactionary policy without embarking on what we would consider a thorough engagement process that involves all of those partners that I just mentioned. So just to give you a sense of the work that we've done around the supports intensity scale, we began that work in 2009, and we've been including internal and external stakeholders along the process. To date, we have conducted over 70 meetings with stakeholders, and we have many, many more planned in 2014. The bill that Senator Kate spoke about a few minutes ago speaks specifically about measures that have been passed here in 2013, a little prior, asking the department to move forward on different areas of changing the DD system. And as you have in front of you, and I don't need to read it today, I provided you an update of where we are in each of those initiatives, because I found it incredibly important to demonstrate to you that we are engaged in all of those and we're involved in implementing every single one of them. So home support within our support waiver, assistive technology within section 21, again, an independent assessment tool. All of those are active initiatives, and we feel like we're headed down the right track. Our approach has been thoughtful, respectful, and informed. We feel that this isn't about immediate gratification. It's really, again, about establishing a sustainable future for adults with developmental disabilities here in our state. As I've said in this room on several times, we are very concerned about the wait list. And my office works with people on a daily basis who are waiting on those wait lists without services. So it's, again, important that we try something different and that we focus on measuring what individuals need versus measuring what other parts of the system need to support people. I hope that's helpful, and I would be interested in responding to any questions that you have, but we're excited about the road that we're on to reform the developmental services system. And as I've met individually with many of you and discussed this, I believe you share our vision and where we're headed, so I appreciate that.
Thank you very much. I just wanted to say that we are very appreciative of the programs that are going on in the department, and we know that you work hard on it and that they are very effective. So I just wanted to mention, Commissioner.
I thought there was a great deal of work put into the stakeholder process, as you know, through the MaineCare Redesign Task Force, and that is specifically referenced as well in this new proposal. So I thought it would be helpful if Stephanie Neto could just go through the various consensus-based savings that were in that report and update the committee on the status of those various initiatives contained within the MaineCare Redesign Task Force.
And we would love to hear that. I think there are some questions from Mr. Martin. Representative Sanderson.
Thank you, Madam Chair. Again, in talking to the senator about his bill, and he mentions the wait list and the cost savings and how he expects to get from what our average of $70,000 per year per person is down closer to the national average of around $42,000 per year would be to take our 1- and 2-person homes and make them 3- and 4-person homes. My question to you, Mr. Martin, is perhaps with some that would work, but what are the challenges to that plan just to achieve savings?
And again, let me speak to work that we're currently engaged in, because we are having that conversation because we too recognize the average cost per person that Maine pays compared to other states nationally. It's incredibly difficult, to be truthful, and it's difficult because you're working with people and you're working with individuals who have lived in situations, and sometimes would prefer to stay. So it's a challenge to have those conversations. It's a challenge to plan. I can't speak specifically to the numbers because I don't know where that $40,000 per person comes to, but in order to achieve that, by consolidating our group homes, which is what's mentioned, it would require conversations with every individual and trying to figure out a safety plan in order for them to move into a different home.
Is there any, what is the plan now that we have in statute? Are we able to do that without having to go and do a state plan amendment? Do we have other challenges like that? Or could we decide to just change our policy now?
The MaineCare policy for Section 21 today specifically looks to establish group homes that are between 2 and 6 beds, 2 and 6. We do have a number of people, a little under 100, who are still in single-person group homes. We have the authority to do that, but again, I can say that having those conversations and engaging the person-centered planning process that we know so well in the developmental services system are challenged. They're all challenging to move that forward.
But Jim, if you could just speak to the vision for Section 29 and the desire longer term, especially around the transitioning for children with developmental disabilities and the role that those services can play, and how we also see that long term in helping to support people with greater level of independence.
Absolutely. As many of you know, and we have had this conversation before, children in transition who are coming out of school and aging into adult services and needing support, some of them are ending up, many of them are ending up on the wait list without services today. So our vision, and we are having conversations with our provider association as well about this, is to get to a place where the Section 29 wait list would no longer exist, and that service would be sort of a minimum threshold, if you will, for people that are coming into adult services. So there would be no gap in their transition from childhood to adults. The other piece of that is that if you can provide a minimum set of supports for somebody that may prevent them from needing a comprehensive 24/7 model, and it may also allow them the ability to become an adult, to relish in independence, to utilize natural supports, and to make decisions that you and I make on a daily basis. So in the long run, we would absolutely like to get to a place where the supports waiver is used. It doesn't have a wait list and is used for anybody that becomes eligible for that service.
Other questions from Mr. Martin?
It was very hard for me to sit here and not comment, but the fact is that what you're talking about are important steps that need to be taken and that are being taken, and I commend you for getting off the dime and moving in the direction, because we do need to develop that bridge for kids that are becoming adults and need to have maybe a little bit of support, but that may be enough until a later time. So, thank you very much.
Thank you.
So, thank you. Thank you. Yep. No problem. So, Senator Craven and Representative Farnsworth, my name is Stephanie Neto, and I am the Director of the Office of MaineCare Services. I will get to speaking about the MaineCare Redesign Task Force that was convened in 2012, but I think it is very important for you to have takeaways when you leave today to think about this bill as it is amended by Senator Cates. And as Commissioner Mayhew did mention, we just received this yesterday and have not had the opportunity to go through with a fine-tooth comb, but there are some assumptions and some questions that I have heard as I have sat in the audience today that I think need to be brought forward, and we need to, some of the misperceptions that I think believe exist. When we talk about funding the wait list with savings from not only the MaineCare Redesign Task Force and individual initiatives through the Office of Adults of Aging and Disability Services, I think it is important to note when Senator Cates was here previously and there was a chart that was presented by a managed care entity, I think it was WellPoint, and they identified $40 million in savings year one. That included all populations being enrolled. I think the misperception is that this is a 3-year phase-in. We would need $45 million of general fund to substantially fund our wait list. So even the savings that were brought forward by the managed care entity with all populations in year one do not get us to funding our complete wait list. I think that is very important to acknowledge and recognize that using savings to fund a wait list that are not there and falsely inaccurate is a serious misperception within this. As we look at using the MaineCare Redesign Task Force, I think it is important to remind everybody on this committee within the budget that required the MaineCare Redesign Task Force, the department took de-appropriations from the Medicaid account, assuming those savings would be achieved. So in essence, we would be double counting those savings if we were to say utilize those savings from implementation of MaineCare redesign initiatives where we have already taken a de-appropriation and we have already implemented the large majority of those initiatives. I have a document that I can present to you, but I will walk through some of the initiatives that we have implemented that were by consensus MaineCare Redesign Task Force recommendations. Concurrent review of psychiatric services that is currently being done by APS. We have implemented prior authorization for elective surgery and prior authorization for high-cost imaging and radiology, PET and CT scans. We are working with our pharmacy benefit manager, Gould Health Systems, to implement a care management model, just as we have on the medical side, for the pharmacy side, focusing on high-cost specialty drugs, outlier utilization, outlier prescribing practices, to do education, and focus on correct prescribing practices and making sure that we are not reimbursing and paying for drugs that are not necessary and those that are extremely high cost. There was an initiative to increase the generic dispensing rate. We at the time, when we brought that forward, or when the task force brought that forward, the department expressed concern over that. Where you have more increase in generic, you reduce your brand. Net, you reduce your cost by zero, because on the brand side, you achieve drug rebates, that is revenue coming back to the state. We have a generic first policy that is in place that requires us to dispense generic drugs unless medically necessary, determined through a prior authorization. We are currently doing that today. There was an initiative to eliminate reimbursement for hospital leave days, and we spent a lot of time in this committee last year talking about this. We eliminated, we reduced, and then the legislature directed the department to raise those again. So there was a lot of discussion on that initiative. The restoration of smoking cessation benefits occurred on January 1st, 2014, as mandated by the federal government. Hospital acquired conditions and no pay for readmissions within 14 days, the department is currently working on. We are submitting a state plan amendment to CMS, and upon approval of that, we will be implementing rules around that. There was another initiative which was called the Healthy Babies Initiative, which we believe is part and parcel of our value-based purchasing initiative and our Accountable Communities initiative. It is imperative that pregnant women receive care necessary through their primary care and their OB offices to make sure that care is being delivered at the right time in the right setting, not only for the mom, but for the success of the baby, and hopefully reducing costs. We have spent a lot of time talking in this committee over and over again about our health homes initiatives, our behavioral health homes initiatives, which will be implemented on April 1st, and our Accountable Communities initiative, which we are targeting for a May 1st implementation date. Overall, we are looking at over 100,000 individuals which will be involved in one of those initiatives, with care management resources both in the community and the department being diverted to managing the care of individuals in an appropriate setting based on quality benchmarks and healthy outcomes. So I think we need to take into consideration those initiatives, and I have information where we can talk about what is the initiative, what is the intent of Accountable Communities. Reduced readmissions, reduced inpatient stays, increased investment in care management. Those are community resources that we are not investing in today, which we made a conscious decision 3 years ago to change the tide and make sure that we were able to reimburse for services that were already being invested in our health systems, our community health centers, and our independent practices. We have talked on numerous occasions about focusing on primary care being the locus of care, being the point in which we need to continue to make sure individuals have access to. Representative Dorney, you talked about how do the providers get paid under a managed care entity, not the contract between the state and the managed care entity, but what's the role of the managed care entity and the provider? As Senator Cates and Dr. House mentioned, that is a negotiated rate between the contractor and the provider. What the department is forced and required to do from a federal regulatory perspective is we have to have an actuarial analysis. So as we've talked about many times with non-emergency transportation, there's a rate range that we are allowed to pay managed care entities. We can negotiate within that rate range, but anything outside of that rate range on the high end, CMS will not participate from a federal funding perspective. Therefore, it would be all general fund dollars used if we negotiated a rate with a managed care entity outside of that actuarially sound rate range. I think that's an important distinction to make, that there is not just the ability for the department to work with managed care entities. There is an added layer in there that has to be considered when this language is debated.
So, just to summarize and conclude.
A question.
Sure you can. It's
not really up to you.
No, it isn't, but I thought I'd act like it was.
And I'll obviously read this more carefully. Stephanie, I think you and I are reading this bill differently. When I read this bill, and my understanding was that the savings that were generated from redesigned task force initiatives related to people with intellectual disabilities would go down. Any of those savings would go to pay down the wait list. You seem to be reading this to say that any savings that were generated by the redesigned task force would go to pay down the wait list. So again, maybe that's something we need to clear up tomorrow, because when I read section